Greetings, DOBBS, and hope everyone is having a good time and keeping well tonight. And this is another episode for our DOBBS on Saturday night live. Though it's live stream, if you catch it later, you can still watch it because the videos will be hosted in DOBBS Facebook as well as in DOBBS YouTube. All right, so you can watch it later. It's no problem. Now, today's theme, I'm going to talk a little bit about retirement because I think the thread of the week in the DOBBS Facebook has been this post by Dr. Agnes Lily, who asked about some advice on people for retirement and wanted to know if you want to semi-retire, what address do you put on your APC? What about the membership in the National Specialist Registration? And then just want to share with you the answers to her questions, actually. And thank you for all those people who shared. All right, there were over 46. There were 46 comments to her post, which saw about 9,000 views. So, so the summary is the MMC will allow semi-retired doctors to use your home address, okay, for your APC. And this is especially so if you want to freelance, say if you want to work in various clinics and no fixed clinic, you can use your home address for your APC. The medical indemnities also will allow you to use your home address and have various coverage. So whether it's MedDefend, Dr. Shield, whatever, you check out their coverage, and they often have good deals for retirees or doctors who work part-time. Okay, there's also coverage for doctors who don't do any clinical work as well. And the really good news, which just came out this week, is there's no more validity period for the National Specialist Registration. So you don't have to keep renewing it every 5 years. So this is wonderful news for the specialists. You just get on the register and that's it. So that's the introduction I have on retirement. I guess doctors don't really retire fully. We sort of like move from one area to the other, some to greener pastures, some to just keep themselves occupied. All right. And now my special guest tonight is somebody who's made that move. So I want to introduce to you our guest for Saturday night, and I'd like you to welcome Professor John George to the stream. Hi, John.
Hi.
How are you?
Hi,
Yeah, John and I were colleagues before at the University of Malaya Medical Center many years ago, before I left in 1999. But John stayed on, and he is a professor of radiology, and he's specializing in musculoskeletal radiology. So for those of you who don't know him, so that's his area of expertise. So he's had a lot of experience in this area, and he would like to share with us his work. He's recently, after 26 years as head of musculoskeletal radiology, he's retired in inverted commas. But as I said, doctors don't really retire, do we? We just move on to something else. So we can't say John is retired, but he's still working. So where are you working now, John? Can you share with the viewers?
Yes, Alan. So currently I'm working in two centers. I have been working at the National Sports Institute. That's been, I've been the radiologist for the institute since 1998, the Commonwealth Games. So I've served in that capacity and continue to serve there. There is an extremity MRI at the unit, and I report that by teleradiology. That's quite a neat unit because you can just sit down on a chair and put your knee into this extremity without going into a tunnel. So I think the athletes love that. And I continued to doing my passion, which is ultrasound. So I'll say a little bit about that. And then when I retired, I also serve or practice at Beverly Medical Center in Tun Razak by and I do that by appointment basis. So when there's a request for me to see a patient, and I think quite a number of the patients that I see actually are doctors.
Ah, okay.
Yeah, because I
Mm.
think because of my experience, a lot of doctors want a senior musculoskeletal radiologist for their opinion. And just to quote an example, I just had a doctor come all the way recently from another state,
Mm.
just last week. After 5 years of suffering from a knee fusion and wasn't sure, nobody could find the diagnosis. She also told me she had a bit of uveitis and stuff. So when I actually did the ultrasound, I did a screening ultrasound. One of the studies that I did recently in before retiring was a very interesting study in which we looked at synovitis of the hands in those with RA patients. And what we found is that those who have RA have this unique pattern of synovitis on the radial aspects of the second and third MCP joints. So let's say they could have something like 4 or 5 of synovitis on the radial side and hardly anything on the ulnar side. And this is seen bilaterally. So we found this in significant number of RA patients. Now, interesting thing, this is also found in those who are seronegative RA. So this was an important finding. That means we could tell the patient if they were EULA or AC, American College of Rheumatology. If they had the criteria, they fulfilled the criteria, but their RF factor was negative. If the ultrasound showed this pattern, the rheumatologists were keen to start them on biologics.
Mm.
So this was
Okay.
very interesting. So this patient actually happened to have an autoimmune arthritis and had a pattern of arthritis in the hands, even though she had no symptoms in the hands, but the synovitis was very significant. And I was able to tell her that the knee effusions were actually a result of a systemic condition, and it was related. So I think this is where, having experience and all the different studies and papers, I'm able to come in when there are difficulties with diagnosis, patients who are suffering for many years, and hopefully I can try and help them with the research that I've done.
Oh, great. I mean, that's, terrific help for the clinician, and especially serology
Yes,
is negative, and
yes,
indeed there's some
correct.
gray areas. And actually, it certainly helps. It's fascinating. And this is just done on ultrasound.
Yes, with ultrasound.
Mm. All right. Fantastic.
So I actually do a screening arthropathy of several joints, like the feet, the hands, and of course, if they have a symptomatic joint, I'll do that as well. But
Mm.
the arthropathy screening is very useful because some patients don't even know it, especially gout. The
Mm.
number of patients who have actually gout, they come to me for tendinitis or something else, and then I find that the pain is actually due to gout. We can see the crystals. And one very important point I'd like to make to the doctors is that your uric acid level can be normal.
Absolutely.
Yeah,
Absolutely. Yes.
so yeah, so finding the ultrasound findings which are very pathognomonic of gout is very important because there are certain features like double contour, snowstorm appearance, different things. Yeah, so that's
Fantastic. Yeah.
yeah,
Mm. Okay. So, I guess you still take with you your vast experience in academia, and
yes,
still, I think you put that into practice. But also, I'm very impressed that you continue to be very active in CME. So maybe
yes,
you would like to share with the audience what you have in store. I think that's going to up. There's going to be an upcoming announcement by the MMA, but maybe we can have a sneak preview of what you have. It's,
yeah,
it's very
sure.
it's very fascinating because this is first time I heard of a customizable webinar. I mean, it's not. We are inundated with webinars, you know. I mean,
Yes,
one day there may be three, four, five webinars, and sometimes you just have to pick and choose. You can't watch everything. But imagine if you can pick and choose and combine what you want to see when you want to
yes,
see, rather than having to adapt to the broadcaster. I say, I'm going to broadcast only on this particular date and time. But here
yes,
you have something where which is quite interesting because you can choose when and what you want to watch. Yeah,
yes.
it's like on demand. So maybe you like
You're,
to, yeah,
yeah.
share with our viewers
So
what
yeah,
what you have.
so this idea really came about because we realized that once we've held a webinar, some people may not have been able to attend that webinar. Sometimes the topics, they are interested in some of the topics, but not all the topics in a webinar. So this idea came to me whether from the we have held a series of 6 webinars in the last year under the I hold these under a company called Global. Global runs the webinars. So what I'm going to do now, if it's okay, Alan, I'm just going to share screen to the flyer
Sure, go
that I
ahead, go
have.
ahead.
Yeah.
Yeah.
So I'll show that. Okay. Can you see the flyer now?
Yes, can. Yes.
Okay. So basically, this is called Global Custom Build Medical Webinars. And this is exactly what you do, build and design a webinar. But of course, as my topics are mainly musculoskeletal, most of the topics will be related to musculoskeletal, but we do have a few other topics as well. So if at the moment, we have already got approval from Malaysian Medical Association, and the main thing with customization is that we have got something like nearly 20 topics. So this is just some of the testimonials from our various webinars that you can see those who have attended and how they have found it extremely useful, so that you have having seen this from other doctors, you have some confidence level with regards to the quality of the webinars that were actually placed. So we come to building your webinar. This is the algorithm. You actually go into the website, and this will be sent out by MMA, by email to all MMA members. And if you need this as well, you can always email me. Uh, or my email is actually quite easy because I'm a musculoskeletal radiologist. So it's just mskrad at gmail.com. So it's easy to remember. So if you look at it, you go into the website, and then you take your time duration, and then you fill in the relevant codes of the talks that you want and submit it. And you also submit the preferred screening day. At the moment, for the shorter webinars, we are trying to have it on Tuesday, Wednesday, and Thursday from 7 p.m. onwards. And you can have a 5-hour webinar on a Saturday. Now, the advantage of a 5-hour webinar is that it gives 8 CPD points, just like our previous webinars that we held, which were 5 hours, which means that you can actually have it on a Saturday of your choice uh, for the 5 hours, choosing the topics. Now, let me show you some of the topics. These are the topics that you can see, and you can see the code that's related to it. So, ultrasound of knee pathology, and it tells you the learning outcomes that you can expect from the topic. So, it's really quite interesting. You actually know what you're going to listen to. So, along with it, I've also included the orthopedic surgeon's input. For instance, they will show the different types of meniscal tear and the type of repair. So, if you look here, arthroscopic repair of meniscal tears. So, what we've done, if a particular talk is useful to be linked with another talk, we actually put it. So, you can see GFO3 is best listened with GFO2. So here I talk about knee imaging for orthopedic surgery, and then the orthopedic surgeon will talk about arthroscopic repairs of meniscal tear and cartilage injury. So, like this, we have the knee, we have the shoulder, we have ankle, all the common. Then we talk about common arthropathy. We talk about requesting musculoskeletal ultrasound instead of MRI, which is particularly useful for the superficial structures. And I think it's very important to understand there's a huge shift from ordering MRI for superficial ligaments and tendons to MSK ultrasound. And the reason is we can first ask the patient to point to where they have the maximal tenderness. And this is very important because if they point to where they have the maximal tenderness, that's where their pathology is. And I'm able to put the probe exactly over that area and then zoom into and see what is the pathology underlying, which we can't do with MR. Then there's a topic on the role of injectables. One of my passions in the last few years is actually using regenerative injections such as PRP, prolotherapy. So I described my own experience with this. As I mentioned, nowadays for the national athletes, our threshold for using PRP for tendinosis, for ligamentous tears is much lower, and it's extremely useful. Quite a number of doctors and others whom I've injected. I think what I'd like to state here is that if you look at the curve in terms of rehabilitation, reduction of pain and function, what the injection does is that it really enables a steeper curve towards the reduction in those symptoms and functionality. So if you were to instead of waiting for 3 months, because in the past people would say you wait only for 3 to 6 months and then you consider an injectable. But in the paper that I actually published regarding PRP and prolotherapy, my argument with the editor who was saying that why are you giving it after a month after physio is I said the patients are suffering and if you were suffering the marked pain and tendinosis and after a month of physio it's not working, you certainly would want to have another therapy, or if you know that the PRP, for instance, like in tennis elbow, it has a tremendous good result. And I'm not talking about weeks, I'm talking like in 2-3 weeks, the patient can be 80-90% better after suffering for months. So, my own personal opinion of these regenerative injections now is that if injected to the correct place accurately, I think that's very important. So, ultrasound guidance to the region and titrating the amount of the regenerative to that region is extremely important. Then we have some other topics, general topics here, which I've shown here. I talk about extremity MRI versus normal MR. I talk about tendinosis versus tendinitis and usefulness of having ultrasound. I give a 6-week rule. If a patient isn't better by 6 weeks, then you should be thinking of referring them. But of course, if you have a screening tool like ultrasound at the first diagnosis, that's even better because you're on the right track. Because a bursitis, for instance, is treated different from a tendinitis. So at the first visit, if you're able to see it's a bursitis, you'll be able to treat it straight away from a different and not send the patient for physiotherapy for tendinitis. I talk a little bit about ultrasound. Some of the GPs and others want to purchase an ultrasound, so I talk about that. And I also talk about care of the ultrasound and optimization. So these are some of the speakers that we have in the list. And this is some of the rates. You can read that later. As I said, this should be sent to everyone by MMA soon. Yeah, so that is a bit about that. And yeah, so let me stop sharing there. Okay, there we
So,
are.
hey, that's fascinating, John. So, I think so. Your target audience would be radiologists
No,
and
actually, our target audience is GPs.
GPs. Okay.
Yeah,
All
yeah,
right.
because we want them to learn about tendinitis, tendinosis, use of ultrasound, because radiologists, they would already know about this, but I think there's a need uh, for uh, GPs and other physicians, because all of us, we like to know a little bit about what others do, I mean, in
Sure.
your own realm. So I think that's what CPD is all about. So the the lectures that we are giving are given at the level of for a GP
Hmm.
understanding. It's not so technical that you will find it difficult.
Do you think
And
they can pick up use of
yes,
ultrasound themselves? Do they
yeah.
need some
So yes, so for
high-powered
that,
ultrasound machine or?
yeah. So what happens is I actually talk about that. I actually show them examples of the level of ultrasound and the pricing that you can buy for each level. For instance, a GP. Then, for instance, a physician who has got musculoskeletal interest, like a sports medicine,
Mm,
rehabilitation specialist.
mm,
So you have the GP level, then you have the physician level, then you have the radiology level. So
mhm,
I talk
mm.
about that and the approximate prices and what you're looking for in in the equipment. So I think for
Fantastic.
GP level and physician level, a lot of it is more quick screening to make sure you're on the right track with your diagnosis. Like GPs are using it for looking at kidney stones and things like that. Same way,
Mhm.
if you can just pick out that this patient has got tendinitis and not a bursitis, for instance, simple things. And then where do we come in as musculoskeletal radiologists? Especially after 6 weeks when a patient is not better. A lot of chiropractors send patients to me as well because they've
Mhm.
done shockwave therapy and other therapy and it hasn't worked. So after 6 weeks, they send the patients to me to find out what's wrong and also to give a regenerative injection at that stage. So we don't
Okay.
rush into regenerative injections. We make sure patients have had their conservative management. But then if they're not getting better, that's when I offer the regenerative injections.
Okay. Very good.
Yeah.
Excellent. So I think GPs and those who are using ultrasound in their practice, I think they should look forward to something which they can enhance their skills and knowledge.
Yeah. So I
Rather than
forgot
just
to
looking.
mention I
Yes.
forgot to mention, Alan, that every year in the last 10 years, we actually have run courses.
Mm,
But because of COVID, we stopped running the course. So we
mm.
have two courses: one for radiologists, which is 4 days, and another for physicians. And we're hoping to start again next year. I think once people have been vaccinated and they allow us to have physical conferences. And the same website that I mentioned. So if you actually want to easily remember the website, you can just look at Google Penang MRI course, or because that's where we normally hold it. We hold it in a hotel in Penang yearly and also in KL. So you can Google penangmskrad.com, penangmskrad.com, and or just Google global MRI course. If you global MRI course, and you'll find the details about Penang MSK Red.
Yeah, that's
Yeah,
the link below,
that's right.
penangmskred.com. Yeah.
Yeah, but otherwise, just put global MRI course, and you'll find it global MRI course, or and you'll find it as well. So we are hoping that if things open up, we'll be able to have our course again. As I mentioned, the website is there. You can see the images of previous courses, the faculty and everything else. So in this course for physicians and GPs, we actually teach basic ultrasound, how to screen, for instance, rotator cuff, how to screen the ligaments of the knee, and stuff like that. Yeah,
So it's physical
it's
meetings,
a
so
yes,
hands
yes,
on and all. Yeah.
it's yes. So
Great.
we have
Great.
the lectures followed by hands-on, and I get a team
Fantastic.
of musculoskeletal radiologists, international and as well as local, to come to help me with the course. Yeah, and we've been having it for 10 years now. Except with the COVID, everything
Yeah.
had to
But the
stop.
COVID has taught us that we can have virtual. I
Yeah,
mean,
yeah,
yeah, and when I think we
yes,
all look forward to real meetings in the near
absolutely.
future. Yeah, I mean, we
Absolutely.
I'm just inundated with webinars, and I said I can't
Correct.
wait. I haven't gone on any overseas meeting for 2 years now,
Yes,
John.
yes, I know,
it's
I know. And for someone like myself who used to attend and
yeah,
speak at about 6 conferences a year,
yeah, yeah,
staying at
definitely.
home is not,
Yeah.
is no joke. Yeah, yeah.
So
In
anyway,
fact, one of the interesting things that I was able to do is in 1998, I brought in the few musculoskeletal radiologists in Asia from
mm,
ASEAN
mm,
together in Kuala Lumpur during the Commonwealth Games.
mm,
And we decided at that time there was an international skeletal society, but there was no Asian or ASEAN musculoskeletal society. So I brought them together, and we actually decided to form the Asian Musculoskeletal Society in Kuala Lumpur in 1998. And now we have about 300 members, and we have a yearly meeting. The recent
mm,
meeting was just held in Hyderabad.
mm,
No, not Hyderabad, in Visakhapatnam in Andhra Pradesh, and had about 600. It was a hybrid meeting.
mm.
I think 200 were attending live, and the rest were, and most of us who were musculoskeletal radiologists from overseas, we gave our talks, recorded talks at the conference. So that was quite interesting. So that is something that very interesting for me to actually be the founder of the Asian Musculoskeletal Society.
Great. Well, I think next
Yeah.
year we'll be seeing more maybe hybrid first, and then
Yes.
physical, purely physical, when things become more normal again, so to speak. So I think you have something else to share, John. Maybe in the remaining time we have something
Yes.
about healthcare reforms. I think you're quite passionate about
Yes.
that as well. Would you
Yes,
want to share with our
yes,
viewers?
Alan, I am because I think for those who don't know, I was actually National SCOMOS chairman for MMA in 99 2000. And at that time, when I was National SCOMOS chairman, I actually put up papers. One of the papers I put up was limited private practice as SCOMOS chairman, and that was actually granted to us by the government. And after that, UMSC was started. And also, I think the KKM didn't follow that pattern. But at the same time, we were very interested in national health reform. And so we were studying this and written up several papers. But I've come to a slightly different conclusion now with regard to the health reforms, because I realized that having a total change like a NHS system or national insurance system that affects the entire system from the GP to the hospital level hasn't been accepted by the government. It's very reluctant to change the current infrastructure of what is happening with GPs, MCOs, private hospitals. So we have to look carefully at what is really affecting the raya, the patients currently. So one of the things that I'm going to share screen here now. Okay, so I've actually written an extensive paper on national healthcare reform. It's basically a concept paper looking at different areas. It has got 23 areas, and the recent addition that I've added is really to focus the national health insurance on out of pocket healthcare expenses, not restructuring the entire system. Because what I found is that I've several uh, uh, friends of mine and also doctors in MMA and others who actually are saying, yes, you see, the government provides me the infrastructure, the surgeon for the operation, but then they tell me that this prosthesis or this intramedullary nail or something has to be paid for separately. And for instance, a pacemaker could cost 18,000 ringgit, and that's not covered. And some of this is not even covered by private insurance as well. So if you were to go into a private hospital, They will cover the base, but they are not covering a lot of out of pocket expenses. So I mentioned, for instance, stents, prosthesis, expensive drugs for chemotherapy. So one of the things I feel is that maybe we might have more success if we can have an insurance that doesn't affect the base of what is already provided, but maybe we can actually look at providing an insurance to cover the out of pocket expenses, so that you don't have to be worried about 20,000, 30,000 extra. Now recently the EPF, I think someone in EPF mentioned that the number of people with enough savings for retirement is really is very few, who will have 240,000. And in fact, a majority, something like 49% of people are having something like 10 to 20,000 ringgit, and this is not going to be sufficient. So imagine if you had an out of pocket payment of 18,000, you'd just be wiped out. So I feel that this area, and also giving payments to GPs for NCD follow up and wellness follow up, I think these are things that can be done without changing the current infrastructure to what is already provided. And this means that the insurance that we are paying, or the government has to figure out how to collect this money, would be more to cover the out of pocket expenses. So that is what I feel that is my point of view now, because there are a lot of people suffering from these out of pocket expenses now. They just can't afford the out of pocket. And I'm not talking about just the poor, I'm talking about the M40 people as well. And even some doctors have said, they have insurance, but after going to the hospital, the insurance said they will not pay for something like 20 or 30,000 ringgit of their expenses, and they have to come up with that kind of money. And the government is the same. I had a friend who recently had to have his toes amputated because he was too afraid to go to hospital during the COVID crisis, and so his diabetes got worse because they were mixing the COVID and the non-COVID patients. So he didn't take care of himself, but now he's had that. The prosthesis for his foot will cost about 5,000 ringgit, and he is in a bad position already, not having work. So I think I am talking now at the moment to MMA, and as I said, if you look at that on my topic, or the concept paper that I have, that was item number 23. So I have 22 other topics where I've actually given my viewpoint regarding many of the issues. And a lot of this was done when I was COMOS chairman. I actually attended overseas conferences in Oxford, and basically spoke to many of the experts who shared with me their ideas, which were not necessarily even implemented, but what they felt should be implemented. But I realized we need to take a different course altogether, because there'll be a lot of objection to changing everything. And that's why I think we're not successful. But it'll be a lot cheaper for us if we just pay an insurance for out of pocket than to pay an insurance to cover everything and change the entire system. So it's something that I'm sharing my viewpoint at the moment, and with Dr. Arasu, the secretary of MMA, and others, and hoping we can look at it in a different angle, and bring in the GPs, which many of the GPs are very interested to take over the follow-up of NCDs, and wellness area, electronic records. So I think this is something they can actually help out. And so we'll have an insurance that covers out of pocket and NCD follow-up, wellness follow-up, because the rest of it is already covered. As someone said, the surgeon is ready to operate in the government, but
Yes, yes.
the base is already there. But unfortunately, they'll tell you this is not covered, that's not covered, and it costs so much. Can you go? And so patients are begging. Literally, my friend had to ask all his friends for $1,000 each, to help him out with the
Yeah,
expense.
that's thinking out of the box, and very interesting, because although the government side is the safety net, but there's still a lot of gaps and unmet needs
Yes,
when it comes to very expensive treatment, very expensive
correct.
equipment. So yeah,
So,
I wish you every success. I think it needs a lot of cooperation on all parties, and
yeah.
I think.
But the good thing is that those I've shared with, they said, well, I
Mm,
mean, that's quite doable. It's something that
mm,
is doable. And and it doesn't require a change in the whole thing, because you're basically agreeing to what should be covered in the out of pocket payments. So there'll be some sort of guidelines. The specialists and all have to say, look, we're not going to let you have some chemotherapy that's not proven, which cost 100,000. It has to be those things that they feel will be accepted in the new out of pocket insurance, and then they will cover it. So there will be some management and some control by some guidelines to the use of that money. It won't just be simply used up. But I think this is a very lateral thinking without affecting what we have, to addressing what the real issue is in the public, and even doctors who have retired. Because you see, it's when you retire that you get all the illnesses, you see. so
that's true.
so
And
so
unfortunately, where
and then
insurance,
and then
yeah,
now you have to
yeah,
use up your savings, and if your
exactly.
savings are used up,
Mm,
50, 60,000 of your savings for out of pocket, that's a lot of
mm,
money. So I think
yeah.
it's a good way of addressing this. So Dr. Arasu has said that he's going to hold a workshop and allow people like us with concept papers to present the concept papers. So I hope he'll do that. I hope
Very
he'll
good.
do that. Hmm.
Okay, now back on the issue of retirement or changing jobs, and
Yeah,
I just want to share with you. I mean, the concept of putting up the physician.my website, which is very easy to remember, is another way for us to network so that we can find each other. And not everybody has a fixed working place. When you retire, you're going to shift, and then how do you find you, what are your latest contacts, and so on. So
yes.
let me share. I think, thank you for using physician.my, John. So I'm going to share your link, and that's
Yeah.
Prof. Dr. John George's link on physician.my. So you can see his current place is actually center of practice is Beverly Wilshire Medical Center. Then you can put the nice thing about physician.my is you can put multiple workplaces. So some people work in one clinic, two hospitals, and so on, and there are different lines. Okay, you can put your email there. And the nice thing is you can put multiple numbers and multiple emails, and you can set each contact as either public, which means anybody browsing the site can see, or private. It means if you set the phone number or email as private, only the doctors who are logged into physician.my can view it. So you can also put in your personal website. So John, you put in your Beverly Wiltshire one, but you can add in
Okay.
also the MSK radiology, and any other link you feel.
Okay.
And
Mm.
we've also put in social media links. So if you have a Facebook page or a LinkedIn page, you can add it in, and there are very nice icons which come up uh, at the bottom.
Okay.
Okay, and then the location is there as well. All right, so people can find you by clicking on it, and it'll take you to Google Maps, and people can easily get directions. Because the biography and the note section is highly configurable. Also, you can put links, you can embed widgets in, and things like that. So you can go to physician.my, and I put the link in the YouTube description to Prof. John George's physician listing. John, I have to tell you,
Yeah.
thank you for being my guest tonight, and you'll get a free smart doctor card for you. So
Uh,
comes
Thanks,
with it.
Alan.
Yeah, yeah, my pleasure. each listing comes with a optional smart doctor card, so you can
Okay.
share your contact with colleagues. When I'm looking forward to real physical meetings, so I say, "What's your contact?" So it's a cool way. You just take your smart doctor card and tap on the other person's phone and send the contact over via NFC or
Yeah.
even NFC QR code. So and this is
That-
highly configurable. So if you change
yes.
anything, you don't have the link is already embedded in your card, so you just need to change your details in the website. Mhm.
Right.
So
Thank you.
okay,
Thank you, Alan, for this fireside chat. We could
yeah,
just share a lot of new ideas, like the custom build webinar, my thoughts
sure.
about national health reform, which are
Mm,
really thinking out of the box to solve the
mm,
issue. So I'm very passionate about this national health reform to help the poor.
mm.
And it's not just the poor, it's the middle income people who can be wiped out
Exactly,
completely.
exactly.
So I'm very passionate about that.
Mm.
And happy that you've given me a chance to share these things that concern me, of great concern to me.
So my pleasure. So
Yeah.
now last week we had a live broadcast as well, and we've asked anybody who wants an opportunity to win a free smart card to comment. There was only one comment on last week's video, and I'm not sure the person is listed, so I've replied to his comment. And his comment, I asked is any feedback on the physician.my website, and his comment was, why not list medical officers? Uh, Unfortunately, I don't think we can list medical officers
Mm.
in this website because medical officers get transferred here and there. So actually, it's more for people with more or less permanent work addresses. So that will mainly be for GPs and specialists, either in public or private practice. So you have a fixed workplace. So it's more for the more senior doctors. So if you're a junior doctor who is being possibly transferred here and there, it's probably not very useful. Okay, so I think that's the target users for physician.my. But we'll have another contest this week for this, and the way is to comment in this YouTube video. All right. First thing is please hit the like button, as they say. Smash the like button and subscribe to our YouTube channel. And then the third thing you have to do to be in contention to our win a smart doctor card is to talk about retirement. What's the what are your thoughts about retirement as a doctor? And if you're close to retirement age, would you just stop work, or would you work part time, or any thoughts about retirement as a doctor? And the best comment we'll pick as the winner for the Smart Doctor card for the physician.my website. So we hope to have some comments. Yeah.
Alan, can I mention one thing
Yes.
about the retirement? You know, when I was going to retire,
Yeah.
some of the doctors actually said that, when you have got, like as in myself, so many years of experience in musculoskeletal, so much of original research. I've only talked about the arthropathy research, but I've not
Mm,
talked about so many other things that I've done, which when I, which are helpful.
mm,
So when it came to retirement, they basically told me you cannot retire. You can semi-retire because we need someone to send the patients to, or even ourselves. Because when, like as I mentioned, this doctor for 5 years they didn't link that it was an autoimmune condition. You know what I mean? So
yes, exactly.
uh, so they said so I think there's a role for semi-retirement when you have a lot of skill
Mm,
and which can be provided. But I don't want to work full time because I feel that you need to also enjoy. You've worked for 26 years, day and night, on calls, everything. It's time to spend some quality time out of the hospital, doing other things, other hobbies. But at the same time, you should not disappear out of sight because your skills are still needed. Someone like yourself, you've seen so many things, and so when you see a patient, and it's like second nature to you because you've already said, look, I've seen this before, I know your experience is there. So being available, I think, in a part-time somewhere to two other doctors with your skills is important to them and also to you, because I feel that if you were to retire completely from one day, being totally active to none, you probably could enter into some depression or so, and that's not good.
Yeah.
So
Yeah.
I think uh, it's good to actually practice somewhere where you can still provide your services and experience, so that people who need your services can come and avail to those services. So that's my take on retirement.
And very well said, John. Very well said. I don't think we should stop. My own take is you shouldn't stop completely.
Yes,
Wind down slowly. Gradually
yes,
wind down, gradually wind down within
correct, correct.
striking the correct work-life balance. It's tough sometimes. But trouble in private practice sometimes work just doesn't let go. You have to learn how to let go to
Yes,
some
yes.
extent. Let go
So this
and
is in a
maintain
way
that.
how
Yeah.
this is how when you have your sessions limited, you know what I mean?
Mm.
So then you're only available in those sessions, so people can only see you. And if they cannot see you, you're not going to put other sessions on, because you say, look, if my sessions are full, and I know some of the Harley Street doctors in the UK, they do that as well. Once
Mm.
the session is full, they say, please see another doctor.
Yeah.
And because
Yeah.
they don't want to work more than 3 days, for instance. If they've decided they want to work 3 days, they work 3 days, and 3 days they are off to their country house, or they're doing other things, and
Mm.
enjoying their retirement because they
Yes.
work so hard. Yeah. So I think that's, but to be available uh, with your skill set, I think is very important, because people need your help. People need
Mm.
your expertise, and it shouldn't be lost by just
Mm.
retiring overnight fully. Yeah.
Yes, and I'm glad you're doing that, John.
Yes.
So
Yes.
and doing other things beyond your field
Yeah.
actually, which
Yes.
I think it's
Yes.
amazing.
Thank
Well,
you.
I think we'll spend about 50 minutes, and it's been a great sharing. I'd like to thank you for
Yeah.
being
Sure,
our guest
Alan.
tonight,
Thank you.
and
Thank you for the
I'll be in
opportunity,
touch with
Alan.
you. Yeah, I'll send you your smart doctor card. But
Sure.
you can
Thank
edit your
you.
listing. I think you need to
I
put in
will.
the MSK
I will.
radiology link to your
Okay.
webinars and so on, and they're up
Yep.
and running. Yeah.
Yep.
Okay. So I'll bid you and all our viewers good night. Feel
Okay.
free to
Bye,
comment.
everyone.
Yeah. Good night, everyone, and feel
Good
free
night,
to comment
everyone.
on our videos on what your thoughts about retirement as a doctor, and maybe you will win your free smart doctor card if you're listed in physician.my. Okay, so we end the broadcast now. So
Bye,
have a good
everyone.
weekend. Stay safe, yeah.